So next up we have Vicky, who works with us at Guy's and St Thomas's. So Victoria Collings is one of our consultant pharmacists. She's an invaluable resource to us at Guy's and St Thomas's, and she does great work managing patients who have atrial fibrillation in prescribing DOACs. She also has a lot of support in terms of our cancer-associated thrombosis service as well. But today, Vicky is going to talk to us, given all of the issues that we now have with the lytic shortages, and she's going to help us consider the ins and outs of substituting urokinase and streptokinase for TPA in lysis regimes. Vicky, over to you.
Thank you very much, Karen, and thank you to you both for inviting me to speak today. So obviously, I'm going to give you some background to the MPSA alert, which was released over the summer. And I'm going to talk about our experiences here at GSTT and how we've considered the different options, discussing some specific drug-related issues, and where we are currently at with regards to management of thrombolysis for patients in this unhappy climate of having a lack of TPA or potential lack of TPA in the future, and how we're monitoring that going forward. So obviously many of you have been aware of this alert that was released on the 3rd of August. So as a trust, the Medicine Safety Officer and governance team coordinated a very quick response to this. We had 5 days to turn around a response, which was a challenge within itself in such a big organisation, and also in early August, where many of our key stakeholders in the trust were actually on holiday. We followed the alert and consolidated the stock and did a stock check initially. We're very lucky to have electronic smart cupboards here in the trust, so much of the stock could be coordinated fairly quickly. We were aware that stock maybe need to be consolidated back in pharmacy, but from critical areas, we didn't remove that stock initially until there was a clear plan. Obviously, it was very high impact alert because of the potential risk to harm for patients, both for obviously life-saving treatment and limb or site, venous access, all the other uses it's used for. We're not actually a stroke centre at Guy's and St Thomas's. Our colleagues at King's manage all the acute strokes locally, but we still obviously have the PERT service, as Karen has explained. The alert itself detailed about use of streptokinase and urokinase. So initially we had a look into those two as our key options for treatment of systemic lysis for pulmonary embolism and PE, as well as catheter-directed treatments. We knew that stock would be allocated to us based on our usual usage. So we had a look at our usual usage, which was not always actually that easy to establish because stock was held in certain areas and not always clear what indications they were used for. We had a certain amount of unlicensed usage as well within the trust for both our colleagues at the Royal Brompton for using it for thrombolysis of VAD devices, as well as for ophthalmology indications, plastic surgery indications as well. So we did an estimation of our stock usage and also immediately put on hold non-life threatening indications and prioritized those for reviewing usage to either streptokinase or urokinase. And then immediately took to rewriting protocols, which wasn't very easy. So in the first instance, I'm going to talk about the use of alteplase. We were using this mostly for systemic thrombolysis for high risk and massive PEs. We have some key advantages of using this that we are very familiar across many clinical areas. administered. It is administered obviously over 2 hours, as many of you know, and there's only 2 ampules that need to be reconstituted as a maximum. We are very fortunate because this has very low levels of anaphylaxis and immune-mediated reactions. So it's very relatively safe drugs, and most of the concerns are related obviously to bleeding, and again making sure that patients are selected appropriately for using TPA in the first instance. I'm going to give you a screenshot. There's quite a busy slide of our protocol, and this is now how we've amended it. You'll see right in the middle of the slide where we've considered where we have alteplase considered as an option. During the alteplase shortage, we would consider other systemic thrombolysis indications, and we have contained all the information about those in the appendix. This is mainly because, obviously, as you can see, it's quite a busy slide and quite a busy page for the clinical teams to follow, but also when we hope that the shortage will be over next year, we'll be able to revert back to the old version fairly easily. So here with the half-dose thrombolysis for intermediate risk PE, we would try and avoid using this as a kind of first-line choice. Obviously, we have catheter-directed as an option, as well as mechanical thromboaspiration, as we are very lucky to have interventional radiology here on site. And obviously, if the patient then goes on and needs full-dose systemic thrombolysis, we have the other stock available in the form of streptokinase and urokinase. This is the protocol that we have also for the high-risk PE. And again, we have included a part of the appendix to detail the different options available for use of streptokinase and urokinase. You can see it here, again, also a busy slide. And again, the appendix hopefully will be able to be removed next year so that we can revert back to the original use of TPA. So the 2 main options, as I've said, would be streptokinase and urokinase, and they both have their problems. So with streptokinase, both streptokinase and urokinase are very old drugs. We have a lot of experience of using them. However, with streptokinase, there's a significant risk of anti-streptokinase antibodies, which both mediate some allergic anaphylactic type reactions in a good proportion of patients, and also make potentially treatment ineffective between sort of 5 days and 1 year, though actually antibodies can persist for up to 4 years in quite a significant number of patients. We would, and how we have explained to use streptokinase in our protocol would be that anyone who have previously had streptokinase within that last year, or if it's a repeat course and they've had streptokinase in the past and there's a potential for treatment failure, we would go for alteplase in the first instance if it's available. The administration is much the same as TPA. It can be administered over 1 to 2 hours. Typically, the number of vials used are very small, between 1 and 6, depending on the stock available. We have had some problems obtaining the high dose ampules, so we're kind of stuck at the moment with smaller doses of 250,000 unit vials, but again, that is still preferable to the next option, which is urokinase. So urokinase doesn't have all the issues with regards to allergy and ineffectiveness due to antibodies, which is good. However, the administration is a lot more difficult for systemic lysis for both high-risk massive PE and DVTs. It needs to be given as a 10-minute bolus and then infusion over 12 to 24 hours. Again, we have a problem obtaining the high strength vials. And even with using vial rounding and dose banding, depending on the weight of the patient, you can end up with reconstituting between 16 and 50 vials. We have explored whether these could be reconstituted in our aseptics unit. and therefore giving a longer shelf life. Unfortunately, the stability data is not available to support it above 24 hours, and therefore that wasn't considered an option. And reconstituting this number of vials in a standard ward environment would be very, very difficult and obviously high risk. Obviously, we teach our nursing colleagues that they should be cautious when they're reconstituting any more than 1 or 2 vials. And so it seems very counterintuitive if we're telling them they have to reconstitute, say, 50 vials of a medicine and infuse it for the patient over 12 hours. With the protocol and how we've updated it, we have tried to reduce the risk of errors with prescribing and administration by using these by dose banding and by having fixed number of vials, again to reduce the risk of wastage as well. But with the infusion over 12 hours compared to other options that would be infused completely within 1 to 2 hours, we feel there's a significant risk in delaying treatment and treatment efficacy. So with regards to catheter-directed thrombolysis, obviously, as Karen has explained, we do use this locally for treatment of PE and DVT, as well as arterial thrombus. Mechanical thromboaspiration will be considered as an alternative in all cases. But we will still continue to use autoplays for certain cases, but other option would be the use of urokinase. So as I said, we have had problems obtaining higher strength, but the 100,000 unit vials we have a plentiful supply of, and thankfully we can use that to for the catheter-directed thrombolysis. It has been used historically, and it's common practice in many other countries to actually use urokinase compared to TPA. And so many, there is evidence-based protocols available, which my colleagues in IR have put in place. Again, the number of vials and manipulations is still problematic. So you're using 24 ampules compared to 1 ampule of TPA. But this is obviously a much more restricted environment than a general ward. And the nursing staff there are very experienced at drawing up the TPA. And we have recommended that their manipulations are second checked. And these ampules, the medicine will be drawn up in the IR department. The infusion started there, and the patient will be transferred to the ward with it running, with an active prescription in place. And therefore, we felt that this actually is the lowest risk situation that we can use the urokinase for. Once it's reconstituted, it's stable for 24 hours. And again, because we haven't got the evidence to support using it for any longer than 24 hours, having it reconstituted and made up in our manufacturing unit wasn't an option, unfortunately. So risk management has been really important during this whole shortage with the TPA. We have an ongoing incident log where decisions and actions have been logged. We have engaged via all the clinical teams and heads of nursing with regards to particularly clinical risk of using other high dose and high risk thrombolytic regimes, particularly with the number of vials and manipulations needed. The highest risk usage was really through high intensity HDU and ICU areas, as well as specialist environments such as interventional radiology. We have updated the IV monograph that's available on all the trust computers, and that's going to hyperlink the new protocols with the dose banding and prescribing information for all the whole trust. We have included, as I said, some practical aspects in the guidelines with the dose banding and recommended number of vials. This also prevents wastage with regards to banding the dosing and preventing miscalculations. We are monitoring all incidences that are reported through Datix with all thrombolytic drugs and assessing them to see if they're attributable to this shortage or not. So far, we have only had one incident since August, and that wasn't related to the shortage. The key stakeholders group have been meeting regularly, and this group includes the chief pharmacist and the medicine safety officer, as well as links back to the chief medical officer and his team. We also have regular updates through other clinical governance committees and the Thrombosis and Thromboprophylaxis Committee, which is a subcommittee of the Drugs and Therapeutics Committee. As you're probably all aware, there was a step down of the alert earlier this month, which is great news. However, a word of caution is that stock is unlikely to return to normal until next year at best, and supplies are still limited for tenecteplase, though we don't really use much of that. We mainly use the TPA. So stock management is really the most important ongoing review. So at the moment, we're quite happy with our stocks of TPA. And we have got stocks available for both streptokinase and for urokinase, but the stock management itself is being checked on weekly by myself and one of my colleagues, as well as the pharmacy procurement team. Stocks are allocated to each trust through their regional pharmacy procurement specialists, and each month an email is provided with what stocks of alteplase, streptokinase and urokinase we will be allocated, and therefore what we are allowed to order. And this will vary depending on what's available in the country, as well as historical and current usage. Mutual aid is encouraged. So if you have other trust sites or linked organisations that you can ask for additional stock, then that would be encouraged in the first instance. If additional stock is needed, so perhaps there was unplanned or obviously emergency stock usage, or perhaps more cases than expected came in, which obviously may of course happen more during the winter, then they should be going through the regional pharmacy procurement specialist in the first instance. Another option we considered was obtaining unlicensed preparation. So there is TPA available to be imported via the US or Australia. So again, a word of caution with regards to this. It's a lot more expensive, though, incomparable perhaps to extended hospital stay. So you're talking £2,000 to £5,000 per vial of TPA. You can order these through the usual unlicensed specials manufacturers and wholesalers, but the lead time is normally 2 to 3 weeks. And if you do hold these unlicensed stocks, then the regional procurement team will account for that in your allocation as well. So if you do keep that, and they will be able to see that you have that, and therefore may reduce your monthly allocations because of it. With regards to the monitoring of both streptokinase and urokinase, fibrinogen monitoring is particularly important, and obviously then the use of cryo or PCC, which at the moment we have no concerns of, but with the latest blood shortage, that's something we need to keep an eye on to see whether that may be impacted from the blood shortage if things don't resolve. The last stakeholders group meeting we had, there was discussion about how we may consider our exit strategy. So we have all these plans in place for using streptokinase and urokinase, both in interventional radiology and also for systemic thrombolysis. So as these seem fairly high risk areas and the use of many vials, we may well roll back on using those, but at the moment we're going to stick with the current strategy, using alteplase when we can, streptokinase first line for systemic, and then using urokinase for catheter-directed where possible. With regards to some of the unlicensed usage, these are very low usage situations generally, such as the thrombolysis of the VAD devices. We tend to only have 1 or 2 a year, so if that does happen, then they will use alteplase for those patients. And then there's a strategy across London for using alteplase for the ocular hemorrhage, and that's a very small dose. Obviously, as it goes intravitreal injection, and again, there's a strategy across London to vial share to make sure that dosage and vials are not wasted of alteplase, and alteplase itself can be kept frozen in glass ampules for several months. So from my understanding is that the ophthalmology group are managing that from Moorfield and also from GSTT and King's. Just like to thank my colleagues. I haven't done all of this work in by any measure. A lot of this has been coordinated by my colleague Anthony, who is the Senior Pharmacist for Anticoagulation Safety. Obviously, Professor Hunt and Dr. Breen have been paramount in organising through TNT, as well as many of my colleagues in pharmacy and in interventional radiology and vascular. And the London procurement team have provided us much advice during this shortage as well. So it's been very team approach.